Hey everyone, we're going to pick back up with the 6 C's of charting. They are very important pieces. One is the client's word must be recorded accurately. So you want to document about what the patient's saying. You can't be biased and put your opinion or your words in their mouth. You have to be sure what you chart is what they tell you. That is the subjective part, what they're telling you. What you see, you're going to chart as well, but the first thing you have to do is be sure you are charting the client's words exactly. Then clarify. If you don't understand what a patient is describing, ask them to clarify. Understand the patient's condition. Ask more questions if you need to. Ask a more specific question. If they say they're having pain, ask what kind of pain, where it's at, how long it's been lasting. You may have to prompt patients because sometimes they get really nervous at the doctor's office. So be sure that you're clarifying whatever their complaint is. Completeness. You have to be sure that you complete the charting. You can't leave pieces of it undone. It is a legal document, and if you don't complete your document, then you have been negligent. You don't want to, and then if it's billed and you didn't complete a chart, then it could be potentially be insurance fraud. So you want to be sure that you complete the chart. Concise. Learn to do your assessment, and you will over time, that you'll to be conscientious and concise with your time. So you can do more than one thing at a time. As you get used to doing your assessment, you'll learn to hone those down to be able to look at a patient's skin and ask them questions about a lesion or a wound or something. You'll be able to, when they say they're having pain and they tell you they have a headache, you're already going to be looking to see if they're squinting their eyes at the light, if they're talking in really quiet tones. You're going to be able to assess more than one piece of their body at a time. Chronological order on dates of all entries. If a patient is coming in today for wound care and tomorrow for wound care, you want to make sure that your dates are all in correctly. You want to make sure that each piece of the patient's chart is in order. It's very important to be chronological if they've had surgeries, you want to put them in the correct order. If they've had wounds, if they've had whatever problems they have, put them in the correct order. And then confidentiality. You cannot share information with anyone who is not directly related in the patient's care. That can cost you tons of money and time in jail. So at a minimum. But also, if you talk about your patient in a manner that someone overhears and gets back to them, then they don't have faith in you. Other providers, if they hear you talking about negatively about a patient, they lose confidence in your ability to float into their area. You want to be sure that the information, you don't want to be in a room talking super loud when you're asking questions. You want to be sure that the people on either side or out in the hall can't hear what you're saying. So the 6 C's are: be sure you're being specific with the client's words. Clarify anything you don't understand. Be complete in your work. Be conscientious with your time, your space, and with equipment. Do it in a chronological order by date. Specific order, specific and putting all dates in. And then be sure that you're respecting your patient's confidentiality. Contents of a patient's chart. Oops, sorry guys. Contents of the patient's chart. They're going to have a registration form. You're going to see that. A new patient's going to fill out a patient history for you, and you're going to have that information. There's going to be a section or a place that you will document test results if they don't automatically feed in. Then there's going to be a place for consult notes and hospital notes. There's going to be a place for diagnosis and treatment plan. There's going to be operative reports, informed consent, and then discharge or other discharge summaries or other correspondence from maybe where they've had some kind of outpatient procedure. Maybe they went for an MRI at an outpatient location, something like that. So those are the main components. Their demographic sheet, which is their registration form. So think of that in terms of a demographic sheet. It's going to say they have their name, address, telephone number, insurance information. It's going to have next of kin. It's going to have all that kind of pertinent information. It may even have why they're there that day. You're gonna have the patient's medical history next, and that's something that you're going to collect on a first visit, and then you're gonna update it at every visit. All test results should be in chronological order. The most recent results should be on top, and on the bottom should be the oldest. They should be in chronological order, in order of date, from newest to oldest. You're going to have your physician's records. You're going to have other hospital records, things like that. You're going to have a physician's diagnosis and treatment plan. So that's your progress note. Any operative reports or any procedural reports that they've had. You're going to have your consent forms, because remember, you can't take care of them if they haven't given you consent. And then any discharge or correspondence from other physicians. Sometimes when patients see a cardiologist, he'll send the doctor a letter. Or sometimes you'll get information from a home health agency or a hospice agency. That's going to be at the back as well. So charting using a SOAP note. SOAP notes are what physicians use most often. So here's what SOAP stands for. You will want to know what SOAP stands for. Subjective data. So we talked about the being subjective and objective data. Subjective is thoughts and feelings about the chief complaint. Like, I'm having migraines. Okay, well, the doctor has to diagnose the migraine, so you're going to ask them questions related to their headache. So it's how they express what's going on with them with words. Next is objective. Those are things you really see. If I have a migraine, I'm going to I might vomit in the office. I'm going to be squinty, or I'm going to be wearing sunglasses, or I'm going to be covering my eyes. Those are things you can see. I may ask someone to be quiet, or I may cover my ears because things are too loud. So those would all be objective things you can see, things that are measurable. Vital signs are objective. Height and weight are objective. So you're going to have subjective and objective data. Then the physician you're going to complete a brief history, which is part of the assessment, and then the physician is going to complete his assessment, and he's going to put a diagnosis and his impression of the patient. So they're going to take some of your information based on the intake history that you get. They're going to ask some more questions, and then they're going to formulate a diagnosis and an impression of the patient and determine a plan. So P is an action plan. What are we going to do to treat the patient? So it's subjective, objective, assessment, and plan. Be sure you know what a SOAP note is, and physicians use them all the time, and that you know what they stand for. Okay? Be sure you know what SOAP is and what it stands for. Recording a patient's medical history. It's going to include pertinent information about not only the patient themselves, but family history. We want to know if mom, dad, or siblings have had high blood pressure, they've had gallbladder problems, have they died at an early age. We want to know that. We want to know any previous surgical history, allergies, what medications they take, and we're going to ask, do your mom, dad, aunt, or uncle, blood relatives have high blood pressure, high cholesterol? Do they have glaucoma? Are there any kind of genetic disorders? We're going to ask those things, not just about the patient themselves, but about their family, brothers, sisters, aunts, uncles, and mom and dad. We're going to ask if a patient's parent has passed away, or they have siblings that have passed away. We're going to ask them how old they are and why they died. I know that seems kind of maybe a difficult thing, but it's important to know, because the physician is going to have to be aware of that so that he can potentially do diagnostic testing or some other kind of studies to make sure that the patient isn't suffering from whatever type of illness that their sibling or parent or aunt or uncle passed away from. Methods of charting. So there's source-oriented medical reports, and that's arranged according to who provided the information. So it's going to give you, and this is a conventional note. So basically, it's going to be arranged according to who provided the information. So it's going to start out with the patient. The chart would start out with the patient information, then the doctor's information, and it would move on down. Then there's problem-oriented medical records, and that's mostly just a database of a problems list with plans of care. You're going to see problem-oriented medical records more in the hospital, and you're going to see that conventional source-oriented medical record more in a doctor's office. Computerized charting, which everyone has gone to in many years, uses both because it's going to pull in information from all different areas. It's going to pull in medications. It's going to pull in potentially hospital records, x-ray records. It's going to pull in what the assessment from the medical assistant. It's going to pull in the assessment from the doctor. It's going to pull in diagnosis, and it's going to combine it all in one record. So know that computerized charting is both source-oriented and problem-oriented. A health history form. It has personal data, and you guys are going to look at one of these. Personal data, chief complaint, what's going on, history of the present illness. So personal data, name, date of birth, your telephone number, address. They're going to clarify that. Hopefully they've clarified that at the front when they check in. Chief complaint, a medical assistant's going to ask the chief complaint. That's what's wrong with them today. We're going to ask them how long it's been going on. How long have you been having nausea? How long have you been having a headache? We're going to verify their past medical history. If they're a new patient, we're going to ask all of their past medical history. The great thing about computerized charting is it stays there and you just update it. We're going to ask about family history. We're going to update family history. Social history, that's going to be things like drinking, smoking, using drugs, the kind of environment they live in. Are they safe in their home? Are they fearful for their life? Those kind of things. Occupational history, what kind of job do they do? Is it a high-risk job that potentially they have, they may have some kind of injury or repetitive loud noises or repetitive motions that can help us with occupational history. Then we're going to do the review assessment. That's that head-to-toe assessment where we ask, are you coughing? Do you have headaches? Do you have vision problems? Do you eat and drink normally? Do you have any trouble eating and drinking? Do you have any shortness of breath? Does your heart beat fast? Do you have high blood pressure? All those review of systems where we ask about each part, each system in the body, each of the systems in the body. Now, in what part of the health history would you record information about whether a patient smokes, drinks, or uses tobacco? We just talked about that. Where would you do that? That goes in the social history. That's the social and occupational history portion of the form. All right. So we are actually done with this part. So we're going to stop here, and we are going to pick right back up in just a few minutes with, and I'm going to add it to this. I just have to pull it up, guys. So give me just a second to pull it up. I'm going to put it on pause for a second, and we're going to start right on with preparing. Okay, we are going to pick up as soon as this loads with preparing the patient's room, preparing our exam rooms to get our day ready for our patient. So preparation for the exam room and treatment rooms, we have to be familiar with the layouts. We have to make sure that everything is clean and it is stocked before patients start coming in. We have to be sure that it's comfortable, that it's not too bright but not too dark. We also have to ensure that it's not too cold or not too hot. We need to keep it comfortable for everybody. Also, safety purposes. We want to make sure that there are things not laying around, that needles are disposed of properly, that we clean the room after each patient, and that safety equipment such as PPE, gloves, masks, goggles, in certain treatment rooms. There's a fire extinguisher available. All those things are done. And that we have a handicap accessible area for patients that need that. So what you're seeing there is a very common medical doctor's office room. You see the otoscope and the ophthalmoscope on the wall, and the probe cover holder, blood pressure cuff, an exam light, an exam table, a chair, a wastebasket, some cabinets, and a Mayo tray at the back. That's that silver tray. A biohazard container there at the back, as well as a glove holder. Rooms need to stay neat and clean. You don't want trash. You don't want a patient to go into a dirty room where the paper on the bed hasn't been changed. You want to be sure that your room is clean and neat at all times. You want to make sure that it's well stocked. If something gets low, don't wait until you run out, because it's going to waste your time and your physician's. So every morning and every evening, you should be stocking your rooms before you leave. You want to make sure all equipment is in proper working order, and that everything is available for the physician as they need it. Now, I'll tell you, in most clinics that have multiple rooms, you have certain rooms that you do certain things in. So it's easier to keep it more stocked. You may have 2 or 3 regular sick or well patient rooms. Then you may have a GYN room where you do pap smears and yearly women exams. And then you may have like a trauma or a treatment room where you would do INDs, incision and draining of wounds, or do wound care, or do stitches. Those are the kind, you may have a certain room set aside that you do that. So it's easier to keep things in order. Also, you want to make sure that you do not leave biohazard or hazardous material out. You want to dispose of your sharps in the sharps container immediately. That is an embarrassing thing to walk in a room and you have not cleaned up after yourself. Also, never poke your needle into the bed that the patients are going to sleep or going to lay on or sit on. Remember, you put that needle into someone's body. Now you've taken it out. If you put it in that bed, you've poked a hole, put it into the foam in that exam room, and you potentially could cause someone with an immunosuppressed system to have issues. So you don't want to do that. So what are the main concerns? A medical assistant's role in preparing the exam room. The main concerns are how it flows. You've got to keep everything flowing for your physician. You're going to see a lot of patients, and it's got to run smoothly. Your physician is going to be depending on you to keep it moving smoothly. So, what are the 3 tasks a medical assistant should do to prepare a room? The first thing you're going to do is you're going to make sure it's neat and clean. You're going to make sure it's well stocked and that it is free from hazardous materials. So maintain neatness, make sure hazardous material are away, and that all of the supplies that are there. Exam rooms are where the physician does his observation, listens to the patient's symptom, and does a general exam to confirm or to diagnose medical problems. An exam room should have a door that can close. If a patient is going to have to disrobe, you need to be sure you respect their privacy. But the exam room is where the doctor performs his exam. Different places have different size rooms. Different places have a different number of rooms. You may have 3, you may have 6. Some places have 10 or 12 or up to 30 rooms, depending on the size of the practice. Most rooms really are 8 by 10, 8 by 12, or 10 by 12. So they're about the size room of most small bedrooms in a home. But they have to be large enough for at least 3 people to get around in, plus enough space for supplies. But they need to be where you can actually access them without having to move and cross over each other or reach across the patient or stress the patient. So it needs to be large enough for you to do your job, but small enough to contain things in a reachable manner. Normally we would have everything arranged to where they are easily convenient and they're comfortable for the patient. Also, it's efficient for time and for procedures. Things you normally find in there, once again, an otoscope, an ophthalmoscope, a blood pressure cuff, probe holder, gloves, biohazard container, a sink, some cabinetry, a stool, some chairs, normal things that you find. Weight and a scale, depending on where you are, that's going to determine whether it's in the room or outside the room. You're going to have a wastebasket with a lid. So these are things that we normally see, like I talked about, things we normally see in the exam room. Special features. In 1990, the American Disabilities Act was passed, and it requires a reasonable accommodation for people who are disabled. All places have to have handicap accessible locations. Accessible means that someone in a wheelchair, someone with a disability can easily get in and out, that there's enough space for them to move around. ADA guidelines. Doorways must be 36 inches wide. Clear, and you guys need to remember the ADA guidelines. I will ask you questions about this. 36 inches wide. Clearance spaces in the room and the hallways must be 60 inches wide. Door closures must be adjusted to allow entry and exit time. So that means if you have automatic doors, they have to be set on a timer long enough for someone to get through that is disabled. Slip-resistant flooring. So you can't have slick floors. You have to have slip-resistant floors. Door opening hardware that can be grasped with one hand and open, and that don't require twisting of the wrist. That they can just be pushed up and down. Also, they need to be low enough for someone who is handicapped or in a wheelchair to reach. And finally, grab bars in the bathroom. You have to have a handicap accessible bathroom with grab bars and space enough for someone to transfer from a wheelchair onto a toilet. So when arranging an exam room, what are the three things you should consider? Space, right? So you need to consider efficiency, patient's comfort, and physician convenience. Efficiency, physician convenience, and patient comfort. You may be in a situation where you are the one who sets up a room in a new practice. Cleanliness of the exam room. Strict housekeeping standards. You don't walk out of a room when you've discharged a patient without making sure it's ready for the next patient. You wipe things down. You change the paper on the bed. You change the pillowcase if you need to, and you put anything away that was taken out and is not there. You want to adhere to government guidelines. You want to make hand washing and infection control a priority at all times. You want to wipe down the tables, wipe down the work surfaces, and you want to wash your hands every time you go into and leave a room. There also will be guidelines for policy and procedure anywhere you work related to cleanliness. You don't leave, if environmental services is not there, you take out the trash. You don't let things overrun. You change out the sharps container when it gets to the right line. You don't keep shoving stuff in it. You follow and adhere to the guidelines of your organization. Once again, hand washing. As you walk in the room, when you start your day, when you walk in the room, when you walk out of the room. If you put on gloves, if you go to the bathroom, if you cough, if you blow your nose, before you handle any kind of equipment, and before you leave for the day. I mean, you will wash your hands so many times you will think your hands are going to fall off, that your skin's going to slough off. But that's okay. That's how you don't get sick, and that's how you don't transmit to other people. Your exam tables, that disposable paper, it has to be changed between every person. If there are body fluids or any kind of biohazard or waste container, uh, you should clean them down. You should make sure that soiled linens and pillowcases go in the appropriate laundry container. Anything that has blood or body fluids on it goes into the red biohazard container. Sharps go in the biohazard container. Be sure that you clean the exam table with the appropriate cleaner. Each location and each place you work will have a different kind of cleaner. It may be a bleach solution, it may be another kind of antiseptic, but be sure you're aware of it and you have some in stock in the appropriate location. So normally we can clean any room no matter where you work with 10% bleach. So that would be 10 milliliters of water to 100 milliliters of fluid. 10 milliliters of bleach to 100 milliliters of water. So that's 10 to 1. That's the ratio, 10 to 1. If I put 1 cup of bleach, I have to put 10 cups of water. That is the appropriate, and for your exam, that is the appropriate, 10 to 1 is the appropriate disinfecting solution. And when you disinfect, you clean counters, exam tables, the patient's bathroom, the sinks in the room. You clean the blood pressure cuffs. You wipe down the otoscopes and the ophthalmoscopes. You wipe down the light. You wipe down the top of the trash can. You wipe off the stool, and you wipe down chairs when needed, patient chairs when needed. Storage. So you also have to be sure that you store biohazardous specimens properly. You don't just leave blood or wound cultures laying around. You bag them and you spin them and you store them in the fridge or however they're supposed to be stored based on your reference lab. Also, testing kits. You don't store testing kits where anyone can get a hold of them. You don't store them in an area where if they're not supposed to be exposed to light, be sure you store them in a dark room. If they're supposed to be stored in a cool, dry area, you don't want to store them in the refrigerator. So be sure that they are stored properly, and to know how to do that, you have to read the directions. As you can tell, cleanliness is a big part of what you do. Be sure that, like I said, clean the room between patients. That doesn't mean wipe everything down, but if there are body fluids or someone's been very sick, if you've had someone in with the flu, if you've had someone in with a bad cold, then you want to be sure you clean that room down. Also, patients know if you're doing your job. They know how clean something is based on what you tell them or what they see. Hang on 1 second, guys. Okay. Okay, guys, sorry. I'm having a little bit of technical issue. It keeps telling me it's speeding up and slowing down the slide. So if there's a problem, you guys let me know. I'm not sure what's going on. Usually there's nobody here late in the afternoons. Once again, cleanliness is a huge deal, as you can tell, based on your job. You have to work hand in hand with environmental services. That's the janitorial service, to be sure that everything is getting cleaned appropriately, especially during flu season. But remember that we are all responsible for the cleanliness of where we work. It is everybody's job. Just because you're the medical assistant does not mean that you don't have to take out the trash sometimes. Trust me, as the director of a bunch of clinics, we had environmental services or the janitorial service that could not come over one day and do our trash middle of the day. Well, that was my job that day because we couldn't have trash overflowing and see patients. So I just went and got the trash cans and emptied the trash and cleaned the trash cans and went on about my day. Because cleanliness and care for the people that you are taking care of and respect for yourself, your job, and your provider, you're responsible for that. And them having a bathroom to go to where there wasn't trash on the floor, was just as much my responsibility as the director as it was anybody else, any other employee that went in that room. So let's see, a medical assistant is at a busy pediatrician's office, notices the foul odor in 2 patient exam rooms. After careful inspection, they find soiled diapers in the biohazard container in both rooms. What should they do? Take out the biohazard. Remove it. Get rid of it. Room temperature and lighting. We normally maintain a room temperature between 70 and 72 degrees. Also, most of the time, we leave doors at least slightly open or closed completely. That way there are no drafts. Most exam rooms don't have windows, and we try to keep the doors where they open in, so there's less draft. Lighting, there needs to be enough lighting that you can see to perform procedures, chart your records, to prevent accidents, but not so much light that it hurts patients' eyes. And then also, exam rooms should smell clean and fresh. The worst thing that you can do is go into a room that stinks if you're a patient. And I'm going to tell you, you're going to have some stinky patients. You just are. What you do is you keep room deodorizer and you wipe down the room before you take someone else in there. If you have to stop using that room and leave the door open and spray it first, that's what you do. But you want to make sure that you go in and you clean a room and you put a little spray deodorizer in there if you have to. Give it a few minutes before you use it so the smell of the disinfectant dissipates. But you don't want patients going into a room that stinks. Okay, we're going to skip past the apply your knowledge, and we're going to talk about medical instruments and supplies. So it is your responsibility as the medical assistant to make sure that all of the rooms are stocked, neat and orderly, that everything is sanitized, disinfected, that sterile instruments are available, packaged, and ready for use, and also that the physician, if he needs a tray set up, it is available, and that your equipment is where it needs to be when you need to use it. That includes blood pressure cuff, that you should have your stethoscope with you at all times, that you have the right size blood pressure cuffs in each room, and that you have accessibility to your thermometer, your pulse oximeter, all of the equipment that you might need. So, instruments in a general exam room. You're going to have an anoscope, which is for anal exams. It's a proctology. It's a proctology tool. An examination light, which is a very bright light that generally has a chrome shield over it, or it may be a small bendable black light, black colored or gray colored light that is very bright, and it's used for exam. A laryngoscope, laryngeal mirrors we really don't use much anymore, but laryngoscopes are generally there. Otoscopes, ophthalmoscopes, those are to look in your eyes and your ears. A nasal speculum in case that there's something stuck in the nose. A pen light. You should have a pen light in your pocket at all times because that helps you check pupils. A reflex hammer should be in the room. A sphygmomanometer, that's your blood pressure cuff. A stethoscope should be available by either for you or your provider. A tape measure should be in there, and that's important because sometimes we need to measure the size of wounds. We need to measure redness. We need to measure abdominal girth. Thermometer, a tuning fork, and a vaginal speculum for cervical exams. So those are things that are normally found in an exam room. Be sure you're comfortable with that list. Be sure that all of the equipment is clean and in good working order. Be sure that things that are mounted on the wall are mounted securely. Be sure that things that are mounted on the countertop are secure and they are accessible. Also, be sure there's a set of clean, sterile towels and that you have a mayo tray available near where you're going to be working. A Mayo tray is that silver tray that rolls around in the room. Preparing your instruments. Some instruments require warming. An anoscope and a speculum, a vaginal speculum, those need to be warmed. A lot of physicians have a warming tray in their in the bed or in the exam table, and those are the things you keep in there. You keep that drawer lined with a clean, sterile towel, and you keep those instruments in there. Once you remove them, then you change out your towel and put in new instruments. Cleaning your instruments. Each type of instrument has a specific solution for cleaning. They may or may not have it listed. If not, you're going to use that 10-to-1 bleach. Be sure that you soak them for a certain amount of time. Then they're scrubbed. Dry, they're allowed to dry. And then if they need autoclaving, they go for autoclaving, which is sterilization. Supplies for the general exam room. Curettes. Those are things to look in and clean out ears. Cervical scraper for a pelvic exam. Cotton balls. Disposable needles, so syringes and needles. Cotton tip applicators. They're like a giant Q-tip, but there's only cotton on one end. Glass slides. Not so often, but we may need other lab supplies. Sterile and normal, regular, clean, latex-free gloves. Paper tissues. You need to have tissue in every room. Kleenex. Specimen containers, blood specimen, urine specimen, wound culture containers, all sputum culture containers, dressing changes, gauze, Band-Aids, tape, all of those things to potentially do a wound care. Occult blood test slides, which you're going to have fecal occult blood test cards. They don't use slides so much anymore as the test cards. Tongue depressors. Those are all consumables that generally need to be in there. You also need to have lubricant available, which would be like a water-soluble gel in case you need to put a catheter in case the doctor has to do a rectal exam or something like that. You want to have lubricant available, as well as alcohol wipes and betadine. You want to make sure that medications and prescription pads are not accessible to the patient. They need to be locked. They need to be put away. Also, be sure that instruments are not visibly seen. Patients, when you're not in the room, will go through every drawer, every cabinet. They'll take a handful of gloves and stick them in their purse. They'll take a handful of cotton balls, a handful of Band-Aids. So just make sure that they're not visible. Put them up in the cabinet. Be sure that I always had the insides of the drawer, little containers inside the drawer, little pencil holder kind of plastic containers, and they were labeled that said alcohol wipes, 2x2 gauze, Band-Aids. That way I knew how to go in. It kept them neat. It kept them arranged, and I knew when I needed to replace the supplies. So if that's not done, go do that. Get that prepared. And then restocking your supplies. Remember to reorder when half of it, when you've got a half to a third of something left. Depending on where you're at or how you're working, you'll have a protocol if you're working for a large facility. If not, your doctor may have you order once a month or once a week or once every 2 weeks. Just make sure you're looking to see what you have, because it's going to have to last you till the next time. So apply your knowledge. A medical assistant is preparing a treatment room at a local ENT, which the following instruments might be needed in an office to assess a patient's ear, nose, and throat. Well, they're going to need a nasal speculum. They're going to need a stethoscope. They're going to need an otoscope. They're going to need a laryngeal mirror. They're going to need an ophthalmoscope, a pen light. They're going to need to check a blood pressure. They're probably going to need a tuning fork. Let's see if I was right. They're going to pretty much need the nasal, the otoscope, and the pen light. But they're also going to have to take a blood pressure. They're going to have to, so there are other things there, but the main things that they're going to use are the pen light, the otoscope, and the nasal speculum. Oops, sorry guys. So, physical safety in the exam room. You want to make sure that spills are cleaned up immediately. Be sure if there are stains in the carpet that someone is aware. Blot them and then make someone aware so they can get clean. Don't leave things that you drop on the floor. Pick anything up that's dropped. Whether you drop it or a patient drops it, pick it up. Safety, safety, safety. Cabinets and drawers should be secured and closed to prevent injury, you hitting your head, patient hitting their head. Also to prevent patients from getting supplies that they don't need that could be harmful. Furniture, you want to make sure that furniture is not worn, torn, or has rough or sharp edges. Be sure that if there is an issue, that it's taken out of service, or and that your supervisor is noted. Cords and cables should be fastened down where people can't trip over them. If they're worn or you see wires, they should be put out for repair. Special safety precautions. Keep medications away from not just kids, but children. Make sure toys are clean and they're age appropriate and that they're not broken or have sharp or rough edges. You don't want someone getting injured and it being your or your provider's fault. Patients with disabilities, same things. You want to be sure that you are mindful of the flooring and handrails. Make sure that rugs aren't flipped up where potentially they could fall over them. You want to make sure that that cords are taped down, that rugs are taped down, that lips, when there's an incline or a decline, that there are signs saying watch your step. Those kind of things are available. Also, always know where your fire extinguisher is. Be sure that no smoking signs are posted and that electrical outlets are not overutilized and that smoke detectors are checked at least twice a year. And also make sure that your fire extinguisher is in date. And if it's not in date, you can get sanctioned. In case of a fire, remember the PASS system: pull, aim, squeeze, and sweep. Remember that using a fire extinguisher, PASS means pull the pin, aim the fire extinguisher at the fire, squeeze the handle, and sweep back and forth. That is PASS. Remember PASS. Have an evacuation route posted. In each location should have a way to evacuate if there's a fire. There should be fire alarms. In a hospital, you will have fire doors that need to close so that it will contain a fire. Also, you should have at least yearly fire drills so that, not necessarily when patients are there, after hours, before hours, for a safety drill, so that you know what to do in the case of not just a fire, but a tornado. All right, we're going to skip to apply your knowledge, and then you have a list of summary. You guys read through that. Have a wonderful day, and I will be back with you. You'll have a quiz on this soon. Thanks, everybody.